My topic is, does rigidity-related mechanical construct factors affect the union time of distal femoral fractures treated with locking plates? As we know, these are very common fractures with bimodal distribution. Fixed angle plates introduced in 1990s became rapidly popular because of their improved fixation, ease of doing, and relative stability. Flexible fixation allows movement sufficient to stimulate tissue differentiation below critical strain level, but too much of movement gives high strain, instability, causes tissue rupture and disturbance of fracture healing. As we know, narrow gap gives higher strain and prevents tissue differentiation. Initial studies show non-union rate up to 6%, but failure to apply this technique correctly, recent studies have shown non-union rates up to 21%, with decreased callus formation and difficulty in healing. Henderson, on his retrospective study of 86 cases, showed that bridge span length, plate length, and bridge span to plate length ratio was not significantly associated with the union. He advised leaving the hole adjacent to the fracture open, that is without a screw, resulted in significantly more unions than non-unions. Similarly, E.K. Rodriguez in 2016 claimed 13% of non-union rates, and 41% of stainless steel construct resulted in non-union, while only 10% of titanium resulted in non-union. There was no other mechanical variable was independently significant of non-union. Similarly, Harvin et al. Said plating constructs with all locking screws were 2.9 times more likely to cause non-union. So he advised more flexible fixation constructs such as increasing working length, decreased proximal screw number, or decreasing proximal screw density were not associated with the union. Recent biomechanical studies comparing the four methods of dynamization by Hansel, as we go from non-lock to bridge to FCL to active plates, the stiffness reduces. Even axial interfragmentary movement is more with FCL and active plates. But the interfragmentary shear movement is more with the bridge plates. So bridge construct as a strategy to dynamize the locking plate is under question because of excessive shear movement and excessive asymmetrical axial movement. So our intuitive technical tricks are not good, and they advise FCL and active plates. Then why this study? If you see, the most of the studies endpoint is non-union. There is no study on exact time of union. New biomechanical studies to reduce the stiffness advise FCL active plates and puts question mark on our earlier practice what we are doing. So our intuitive technical tricks which we follow, like tapping of the locking screw or use of cortical screw, doesn't have statistical support. So main objective is to study the factors of rigidity with regards to union time and to identify the factors, independent factors of union. It was a retrospective case control study from 2015 to 17. 32 patients of distal femur fractures treated with locking plates were included. We excluded the open fractures, diabetics, CKD patients, smokers, steroid dependents, and incomplete follow-up. In all, we had 23 eligible patients. The main outcome measure was union time. Construct variables assessed was plate length, empty holes, total field screws, total screw density, proximal screw density, and rigidity score. Additional variables like age, AO classification, and injuries were also assessed. TSD is total screw use divided by total screw holes in the plate. PSD is number of screws proximal to the fracture divided by number of screw holes in shaft of the plate. Score is calculated from 0 to 3. 1 point if screw crosses the main fracture, 0 point if PSD less than 0.25, 1 point if between 0.25 to 0.6, and 2 point if more than 0.6. This is an example with different TSD and PSDs. First has PSD 0.55, second 0.6, third is 0.38, depending on how many holes you fill. Similarly, score, if you see both the X-rays, plate length is same, 10, but the number of proximal screws is on left side is 4 with PSD 0.4, the score became 1. On the right side, the proximal screws are 6, so PSD was 0.6, so score was 2. Results, all the fractures were united with index procedure. There was no case of non-union. If you see the relation of PSD with union time, we had 18 patients between the group 0.25 to 0.6 with mean union time of 19 weeks. We had 5 patients with PSD more than 0.6 with union time of 35 weeks. 2 sample t-tests showed p-value of 0.0013 with degree of freedom 21, and p-value was less than commonly chosen value, so we rejected the null hypothesis. The first example, the PSD 0.55 union time was 12. With PSD become 0.6, the union time was 48 weeks. The last X-ray PSD was 0.38, the union time was very less. Similarly, there was significant relation between rigidity score and union time. We had 18 patients with score 1 had union time of 19 weeks. 4 patients with score 2 had union time of 35 weeks. We had 1 patient with score 1 who had a union time of 40 weeks. 2 sample t-tests showed p-value of 0.001. Earlier example, where PSD was 0.4 and score was 1, union time was 12 weeks. With a score 2, though the PSD was 0.6, union time was 48 weeks. Another example, PSD 0.55, but there was a screw crossing the main fracture fragment, so score became 2 and the union time was 40 weeks. There was no relation with type of fracture and union time. P-value was 0.0077. So multivariable analysis was done using logistic regression table, age, plate length, plate holes, empty holes, total field screws or TSD was not significantly related to the union time. PSD and rigidity score of the construct were directly affecting the union time. So in all conclusion, union time depends on construct stiffness. Delayed union is most common than non-union. Score more than 2 or PSD more than 0.6 leads to delayed union. So we should aim to achieve the PSD less than 0.6 to make the construct more or less rigid, which will enable micromotion and avoid the delayed unions. Thank you.